and gentlemen, it is my great honor to be invited here today. I would like to thank the organizing committee for inviting me. Small-sized ACCs are more frequently detected than before due to development of CT and MRI technology, as well as surveillance programs of ACC. Although this is good news for patients and physicians, it is not always good news for interventional oncologists. Let me explain why. Small-sized ACCs are not easy to detect on ultrasound. In this study, even though plain ultrasound for RFA was performed by radiologists who were aware of the size and location of the tumor, the detection rate of small ACCs was much lower than expected. Therefore, we have a hard time ablating these small tumors under ultrasound guidance. This is why fusion imaging is needed. So, what is the fusion imaging technique? It is a technique that uses ultrasound and CT or MR. Theoretically, it seems to be ideal since ultrasound can provide real-time imaging and CT or MR provide high-quality images with good contrast and spatial resolution. Therefore, while we are performing real-time ultrasound, the fused CT or MR imaging shows the same plane and moves synchronously. This technique allows us to detect a target lesion which has poor sonographic conspicuity. As you may know, there are various fusion imaging techniques developed by different companies. Volume navigation by GE, POCNAV by Philips, Smart Fusion by Toshiba, real-time virtual sonography by Hitachi, and virtual navigator by Esaute. Among them, in this presentation, I will show you volume navigation technique based on my experience with this system with more than 700 cases of RFA. Let me show you some representative cases. In this example, you can see a small ACC in the liver bone. On plain ultrasound before image fusion, a small X-ray nodule was identified and it was considered the ACC detected on MR. However, after image fusion, two index tumor was located at a different site. Therefore, we can say that the region identified before image fusion was a pseudo region. Obtained RFA was performed with confidence, and immediate post-RFA CT scan shows that it was a technical success. This is an example of RFA case in which mistargeting was avoided by using fusion imaging technique. In this example, you can see a small ACC in segment 5 of liver. On plain ultrasound prior to image fusion, the index tumor was invisible. However, after image fusion, a subtle echogenic lesion was able to be detected where the index tumor was located on the fused MR images. Obtained RFA was performed after introducing artificial ascites to avoid thermal injury. And immediate post-RFA CT scan shows that it was a technical success. Another example, here you can see very tiny ACC nodule in segment 4 of the liver. On plain ultrasound before image fusion, the index tumor was totally invisible. It was invisible even after image fusion. However, you can see nice correlation of portal vein and its branches between real-time ultrasound and fused MR images. Using these vessels as peritumoral anatomy landmark, an electrode was able to be inserted at the expected location of the tumor, and RFA was performed. And immediate post-RFA CT scan shows that it was a technical success. This is a table showing the detection rate between conventional ultrasound and fusion imaging for 137 ACCs. False positive detections on conventional ultrasound were regarded as undetectable lesions. As you can see, the detection rate was statistically different between conventional ultrasound and fusion imaging for HCCs smaller than 2 centimeters, whereas it was not for HCCs 2 centimeters or larger. Therefore, we can say that fusion imaging is useful for HCCs smaller than 2 centimeters in diameter. Fusion imaging is also useful for guidance of RFA for large ACC. Here you can see 3.3 centimeter size ACC in right of liver. On plain ultrasound, the tumor was measured up to 3.5 centimeters. I felt uncomfortable to ablate this large tumor. Fusion imaging guided RFA was performed. 3 electrodes named octopus electrodes were inserted into the tumor one by one to cover the entire tumor. Although the quality of image fusion was ideal before needle insertion, after needle insertion, it became unacceptable. Let me explain why. Since liver is stiff in patients with liver fibrosis, there is moderate resistance while placing the electrode, which results in rotation and displacement of liver from its original place. Therefore, this registration after needle insertion is inevitable. To overcome this problem, we can use 3D ultrasound that can be used for image fusion. One thing to point out is that 3D ultrasound should be obtained after needle insertion, not before. On the left are real-time ultrasound during ablation, and on the right are fused 3D ultrasound obtained after needle insertion. Based on fused 3D ultrasound obtained after needle insertion, we can say that ablative margin here is not sufficient. The advantage of fusing with 3D ultrasound is that after ablation, we can directly compare real-time ultrasound with fused 3D ultrasound, and thereby evaluate whether ablative margin is sufficient. If not, we can position the electrode where needed. The location of the electrode in relation to the tumor is easier to recognize on 3D ultrasound, and this makes the positioning of the electrode more convenient. Multiple overlapping ablations were performed. Now, the echogenic zone seems to be large enough to cover the entire tumor, and immediate post-RFA CT scan shows that it was a technical success with sufficient ablative margin. Although fusion imaging technique is a promising technique, it is not always perfect. Mistargeting can occur even though fusion imaging is used for guidance of RFA. This is a table showing the mistargeting after fusion imaging guides RFA. In this study, the most common cause of mistargeting was small size of ACC, followed by confusion with pseudo-region, subcapsular, and subplane location. Therefore, we can say that fusion imaging has limitations for small ACCs located in the periphery of the liver. To be sure that the nodule identified on fusion imaging is the true ACC, I recommend you to use contrast-enhanced ultrasound additionally. Here you can see a small ACC in segment 6 of the liver. It is located in the periphery of the liver, so it is a challenging case. On plain ultrasound, a certain low echoing nodule was identified, and it was considered the HCC identified on MR. At the time of RFA, again, a subtle low FM region was identified. However, to be certain, contrast-enhanced ultrasound was performed. On arterial phase, when the patients breathed in slightly, two enhancing tumor was identified at the different location. Therefore, we can say that the region identified on fusion imaging was a pseudo lesion. The lesion was seen as a defect on Cooper phase. It was inserted into the tumor with high confidence, and RFA was done. Immediate post-RFA CT scan shows that it was a technical success. This is a case of RFA in which mistargeting was avoided by combined using of fusion imaging and contrast-enhanced ultrasound. Traditionally, contrast-enhanced ultrasound has been performed under this combination, but when fusion imaging is available, it can be combined with cross-sectional imaging such as CT or MRI. Combined use of fusion imaging and contrast-enhanced ultrasound has advantages over contrast-enhanced ultrasound alone. With fusion imaging, we can estimate the location of the index tumor before injecting contrast agent. Therefore, it is easier to detect a nodule showing arterial enhancement at the first injection. If so, we can avoid second injection of sonazoid, thereby reduce overall procedure time. Therefore, when the fusion imaging is available, contrast-enhanced ultrasound should be performed with fusion imaging, not with conventional ultrasound. I would like to summarize my talk. Fusion imaging is useful for localizing inconspicuous regions on remote ultrasound, and it can facilitate accurate RFA procedures. Thank you for your attention.
My theme is combination therapy of TACE and other population. Today I'd like to talk about HCC first, followed by colorectal cancer liver metastasis. Okay, let's get started with TACE and other population for the treatment of HCC. This shows what are important when we treat HCC lesions by other population. At first, we have to approach to the target tumor precisely. Second, we have to create a ablative zone large enough to encompass the tumor, and we have to prevent collateral damages. These things lead to increased patient survival. Today, I would like to talk about the second topic, to create ablative zone by using the combination therapy. This shows the percentage of patients in whom complete tumor necrosis was achieved based on tumor size. If the tumor size is 3 centimeters smaller, in more than 90% of the patient, tumors are completely ablated. But as the tumor size becomes larger, the percentage of complete tumor necrosis becomes lower. From this data, good indication for RA population alone is reported to be 3 centimeters smaller. This shows the maximum tumor size at the time of initial diagnosis of HCC lesion. If the tumor size is if the good indication for RA population is 3 centimeters smaller, only half of the patient benefit from RA population. If we can achieve complete tumor necrosis in HCC lesion up to 5 centimeters, almost 70% of the patient benefit from RA population. Local tumor control is very important. If local tumor recurrence does not occur, if local tumor recurrence occurs, the 5-year overall survival rate is 42%. But if there is no local tumor recurrence occurs, the overall 5-year survival rate is as high as 84%. But there are some difficulties when we treat HCC by RF ablation. This slide shows the microsatellite distribution around the main tumor. If the tumor size is 3 cm, almost all satellite lesions are within 5 mm from the main tumor. So we have to create a ablative margin at least 5 mm from the main tumor. And as you know, there is a limitation in RF ablation. It's a heat sink effect. We performed animal studies around 10 years ago. We performed RF ablation in the pig kidneys, and we got a large round ablative zone in the lower peak, but in the upper peak, the ablative zone is very limited, and the size is very irregular. What's the difference? We performed RF ablation after we occluded the renal artery in the lower peak, and we performed RF ablation alone in the upper peak. This is very clear. Occlusion of arterial blood flow, occlusion of the renal artery expand ablative zone size. There are many ways to block blood flow in the liver, but as you know, TACE is most popular and familiar. This slide shows the rationale of TACE and RF ablation. As you know, TACE alone has a strong anti-cancer effect on HCC lesion, and it is effective for the control of satellite lesion, and the tumor margin becomes clear after TACE, and it is useful in evaluating ablative margin on the follow-up CT. And it may be possible to ablate tumor cells in outflow area. I'll show you later. And intratumor pressure does not rise during RF ablation, leading to prevention of tumor seeding. Maybe, as Dr. Orim said, maybe we can prevent transportal tumor spread, and it is useful in preventing hemorrhage. Let me show you one case. This is a case with HCC lesion measuring 5 cm in maximum diameter. At first, we performed TACE followed by RF ablation. We are using real-time CT fluoroscopy like this. We have 3 images. This is the head side, center, and the foot side. This tumor is a little bit large, so we plan to place 2 RF electrodes in both the back side and the front side of the tumor. Now we placed one RF electrode in the back side, and we are placing another one in the front side of the tumor. We call this method the chopstick method. Now we are confirming the placement of RF electrode and moving the table from the head to the foot. Now you can see a bubble formation in the backside of the tumor. The heart is beating. Yeah, you can see bubble formation, and the heart is beating. And now we are moving the table from the head side to the foot side. Now, and then you can see a bubble formation in the front side of the tumor like this. And now you can see bubble formation entire the tumor. And you can expect good results on the follow-up CT like this. Let me show you a recurrent case from outflow area. This is CT-HA image. This is a main tumor. And after TACE, you can see an outflow area in here. There may be some tumor cells in here. But this is the initial case, and we performed RF ablation for main tumor alone. This is the result. The result seems to be very good, but we did not ablate the outflow area. And this patient experienced the local tumor progression from the outflow area. These days, we ablate both the main tumor and the outflow area to prevent local tumor progression. We measure the ablative zone size after the combination therapy like this, short axis and long axis, and compare the ablative zone size with early population alone. These are results. Ablative zone size was expanded after the combination therapy than the early population in both the short axis and long axis. And this slide shows the complete tumor necrosis rate after the early population alone, blue bar, and after the combination therapy, orange bar. And you can see that we can get complete tumor necrosis when the tumor size is 5 centimeters smaller. This is data from Yokohama State University. They compare the local tumor progression rate between early population alone and the combination therapy in patients with HCC measuring 3 to 5 centimeters. The result is very clear. The local tumor progression rate is significantly lower after the combination therapy. We compared the overall survival in patients with early HCC lesion 6 years ago between the combination therapy and surgical intervention. Although this is a retrospective study, we know that this combination therapy can provide the same survival rate as that after surgical intervention. Recently, we've got the overall survival rate up to 10 years after the combination therapy. 277 patients received this combination therapy, and 1/4 of the patients survived over 5 years. The 5-year survival rate is 66%, and 10-year survival rate is 31%. And child preeclampsia is a significant prognostic factor. And if the patient had child preeclampsia liver profile, the 5-year survival rate is as higher as 70%. Again, that is same as that following the hepatectomy. How about the results when we treat large HCC lesion? Let me show you one case. This is a case with large HCC lesion.